Good evening. I, Nitin Modi from Nishiro4 welcomes to our audience, welcomes to our speakers, Dr. Dinesh Kale from Belgaum, Karnataka, Dr. Atul Patil from Sancheti Institute for Hospitals and Rehabilitation, Pune. I welcome to our speakers, Dr. Pradeep Nimade, sir, consultant orthopedist in KEM, Mumbai, and Dr. Srinivas Kasha from KIMS, Hyderabad. Now I hand over the session to Dr. Dinesh Kale, sir.
Hello. Good evening to all of you. We are 4 orthopedic surgeons who will be showing you the approaches to the acetabulum. Our aim here is to show you how to expose the fracture. How to go ahead with the fixation is a different ball game. There are 4 approaches that will be shown. Dr. Atul Patil, Dr. Pradeep Nimade, and Dr. Kasha have got a very large experience in acetabular fracture. All of them have done more than 300 to 400 cases of pelviacetabular fractures. And the first, we will be starting with the most commonest approach that everyone is accustomed to, and that is the KL approach. Well, this is the place where I work. It's the KLE Hospital in Belgaum. Just a few words where we use this particular approach, which is the KL approach. It is for the posterior column and for the posterior wall. Now, associated with the posterior wall or the posterior column, you can have the transverse fracture, T-type fracture, both column fractures. As a rule, one should get some of the X-rays which are necessary, the AP, the obturator view, the ILAC view, and one should get familiarized to see the acetabular fracture on these views. When should you operate? A dislocated hip with a posterior wall fracture is an emergency and the dislocation has to be reduced. Fixation of the posterior wall is to be done in a decent, comfortable time. An unreducible hip dislocation is an emergency for open reduction. A due preoperative consent is necessary, and one should also take into account the possible complications that have been listed here. Now, this KL approach can be done in 2 fashions. One is in a prone position, the other is in a lateral position, which is also called as a floppy lateral position, because the patient is not very tightly positioned in a lateral position. We should be able to move the patient slightly towards the prone side and slightly towards the supine side, because sometimes when there are associated fracture, we should be able to approach the other side. Now, what are the advantages of a lateral position? All of us are familiar with this approach when we are doing a hemi or a total hip surgery. The position allows simultaneous anterior and posterior approaches if required. What are the disadvantages? If the patient is very bulky, the head will always be pressing over the acetabulum. So you will require an assistant to keep it up. Constant traction via femoral pin has to be maintained by an assistant. Application and maintenance of a lateral traction becomes difficult, and IITV imaging is difficult in a lateral position. In a prone position, the only difficulty is the manpower required to position this patient. You will require at least 3 or 4 sturdy people in the OT to keep this position of the patient on the table. The advantage is the imaging is good, the traction can be maintained, you can distract with a traction apparatus. When you are passing the screws, this is a good position because your IITV imaging is better. However, the thing that you have to remember is the knee has to be kept flexed in 90 degrees. The disadvantage is our orientation becomes exactly in the reverse fashion. Chances of the sciatic nerve traction injury are higher. Now in prone position, as you see here, this is the PSIs, that mark that you see here. We are going exactly in a reverse direction. These are the stepwise exposures. Why we are familiarizing you with these pictures is this is exactly what you are going to see either in a lateral or a prone position. The exposure has to be really big. The Gmax tendon usually requires to be cut so that the pressure on the sciatic nerve is prevented. You have to carefully tag all the tendons that you cut, except do not cut the quadratus femoris. One should not cut the capsule. You have to go in between the capsule and the tendons. Identification of the gamellae and their tagging is important because it is the gamellae, when you reflect back, it is going to act as a cover for the sciatic nerve. And your gamellae is going to lead you to the posterior column. Without detaching any soft tissue, you should clear the hematoma and as little as possible dissect between the capsule and the fragments. If there is a wall impaction, you should look for it and try to disimpact it. See, normally the white structure is never seen, it doesn't face you. If it is facing you, it means there is a wall impaction. Oriented the wall to the head fragment so that it will get correctly placed, and the gap created after elevating this fragment has to be filled by a bone graft. Now you see here that the wall has been relocated over the head. It is being pressed by a ball spike. Now it has covered. You don't see the white articular cartilage of the wall. Temporarily fix it with K wires. Your direction of the screws has to be away from the joint. One cannot afford to fix any screws in such a way that it enters the acetabulum. So these are interfracs. Once you have put the interfrac screw, you'll have to put a plate. This is a picture with the interfracs and a plate which is buttressing this fragment. This is the final picture that you get once you have buttressed this. It's a good habit to mark your pieces on a bone model and place them by a picture drawn on a white paper. You can use the cover of your gloves, draw it on that and place it. Otherwise, when you are starting to place this fragment, you will spend time in getting the orientation. Sometimes you may require a distractor if the fracture fragments and the posterior column has to be distracted. Now we will straight away from here go to the video which will demonstrate all these steps. This is the positioning of the patient with the incision marked. They are self-explanatory videos. Once you reach the tensor fascial lata, take away the fat from there by using a Cobb elevator. Open the TFL in the same line of the incision. After that, you have to excise the trochanteric bursa. Now, what we are exposing is the gluteus maximus tendon. Now, there are vessels under this. You will need to cauterize them. Tag this tendon because at the end of the surgery, you will require to suture it. Identify the quadratus femoris because we should not be cutting the quadratus femoris tendon. Now the index finger goes under the rotators in such a way we are trying to separate these from the capsule. Sometimes the dislocated head can puncture through the or button out through the piriformis and can cause a tear in the piriformis. We have to leave a 1 to 1.5 centimeter tag on the side of the femur so that it enables us to suture it. It is not like the way we do in a hemi where you go flush with the capsule and the rotators.
Of the three, the obturator is the strongest tendon, and see when I pull on this, I am able to completely move the patient. The obturator this is the strongest very strong tendon, and see when I pull on this, once you tag I am able to completely move the patient. Under the surface of the obturator, this is a very strong tendon, and once you tag this, if you start dissecting under the surface of the obturator, it will lead you to the ischium.
I have tried to amalgamate videos of 3-4 patients together. So you might find the difference in the fracture and the incision levels, but it is just for you to make you understand. Now this we are cutting the obturator index and the gemelli, and now we will be working from inside of this so that the sciatic nerve is well protected. One should visualize the sciatic nerve, but need not dissect it. You have to just confirm that it is in the continuity. However, if there is a palsy, then one has to go and completely visualize the course of the nerve from the greater sciatic notch downwards. Now, this is we are debriding the fracture site, removing the hematoma and the debris. See, with my finger, I am just holding the fragment up. I have not dissected the fragment of its capsular attachments. Now from the under surface of the wall piece also, remove all the clots. You can see the head very clearly there. You can see a small cartilage piece that has been separated. that has to be removed. You can distract the joint and even probe it with a thin bent L wire to see if there are any small cartilage pieces inside. Now I am exposing the posterior column. This is under the obturator and the gamellae. The sciatic nerve is towards me. Now that is the fracture site that has been cleaned and ready for the wall piece to fall back. Here I am demonstrating on a bone model to the postgraduates who are there exactly where this fracture piece has come and how we are going to fix the interfrag screws. That will be the direction where we are going to pass the screws. Now using a ball spike, I have stabilized it and I'm going to pass 1 or 2 K wires so that the wall piece is fixed. And once
Now if you see my spikes, the upper spike is going into the greater sciatic notch. This is the greater sciatic notch here, and this is the lesser sciatic notch. Now from here to here, upper spike is the wall is going into the greater sciatic notch. Here is the posterior column. This is the greater sciatic notch here, and this is the lesser sciatic notch. Now from here to here, position back onto the wall. From here to here is the posterior column. This is the broken wall piece. This is the broken wall piece. Now I shall be passing screws which will position back directed from here to here. This is the broken wall piece which I have positioned back. Putting a plate on top of this. Now I shall be passing screws. No screws of the plate will come on this. From here to here, it will try to press onto this and then putting a plate on top of this. The only thing now I have to take a decision is no screws of the plate will come on this. If I am able to put 2 screws, then I need not do a GT osteotomy. Press on to this. Feel that the tension on my gluteus medius. The only thing now I have to take a decision. Then I may, if I am able to decide to 2 screws, then I take not do a GT osteotomy. Superior purchase. But if I feel that the tension on my gluteus medius is too much, should be good enough to, then I may reduce decide to do a trochanteric osteotomy to get a superior purchase here. But I feel here I should be able to get 2 screws, which should be good enough to the column reduce this fracture. And now this shows that I have temporarily fixed the posterior column by screws which are going to be directed in this by 2 K wires. And now I am going to fix it to the posterior column by screws which are going to be directed in this fashion.
Now here we are drilling for the screw trajectory. Once we have confirmed under the IITV that our direction is not towards the fracture site. I'll just pause here. Now this is a video clip of another patient where the fracture site is at a 12 o'clock position. Now at this position, if you are going to put your retractors under the gluteus medius, it is going to cause quite an amount of traction over the superior gluteal vessels. So the next part of the video will demonstrate how to do a GT osteotomy. it should extend right up to the insertion of the vastus lateralis. You have to take a part of vastus lateralis in the osteotomy. One spike goes at the base of the trochanter where the vastus lateralis is inserted. You demarcate your osteotomy site. And with a saw, take off the GT in such a way that it is not too thin, so that when you evert it, it should not break. And it should not be so thick that you go across the piriformis tendon. Now, once you reflect this, your accessibility to the fracture at the 12 o'clock position of the wall becomes much more easier, and your traction on the gluteus medius is reduced. Now here I am fixing the superior wall pieces. That is how the pieces will look under the IITV imaging. These are the interfrags. Now one should template so that you will know what is the length of the plate required. The plate has to be pre-bent in such a way that the curvature is along its length and along its breadth also. There should be no screws that will pass in the wall fragment which is covering the head. This is the ischial tuberosity. This is the posterior column. This is the fracture in the posterior column, if you can see here. Now here I am fixing the GT after the fixation of the wall. This is the posterior column. This is the fracture in the posterior column, if you can see here. This is the fracture in the posterior column here. This is the impacted articular surface which we are going to lift off from here and put a bone graft here. Now I am trying to slowly lift that impacted posterior wall fragment and bring it over the femoral head, and the gap created in between this will be filled with bone graft. Now that shows the wall fragment completely brought back to its original position. And where my middle finger is, there will be the graft that will go in. Now that is the end of the video. Now I request Dr. Atul Patil to present his video. Atul, go ahead.
Yes. Good evening. Good evening, Kale sir, Pradeep and Shini. Today I will be speaking to you about exposures, what we can achieve with the help of modified iliofemoral approach. Can you hear us? Hello?
We can
Yes,
hear
sir.
you properly.
Yes. So,
Yes, we can hear you.
modified iliofemoral approach can be done in isolation. That is number one. Second indication, it can be combined with modified STOPA, that is anterior intrapelvic approach, or it can be combined in Cocker-Langenbeck approach. The most important thing about to know that this is a approach which you can do in supine position as well as you can do in semi-supine or lateral position. So when I do this iliofemoral approach along with the AIP, that is STOPA, I keep the patient in supine. And when I do this approach along with the Cocker-Langenbeck approach, I keep the patient in lateral, perform Cocker-Langenbeck approach, and do the semi-supine position and perform modified iliofemoral approach. So this is the position. And what is the reach? You should know each approach, what it can reach, which bone you can reach up to. So each approach, posterior approach, anterior approach, intrapelvic approach has its direct reach or indirect reach. Here in modified iliofemoral approach, it's very good direct approach for iliac blade and excellent for false pelvis, iliopectineal eminence and anterior sacroiliac joint. You can go on both sides of AIIS, that is anterior as well as posterior, from where you will able to pass a anterior column screw or a posterior column screw or a LC2 screw. So many screws can be performed with the help of iliofemoral approach. And indirectly, this can reduce quadrilateral plate, posterior wall or anterior column where you can pass your fixation. So here we can see that in this picture, if you see, this is a head end and this is a leg end, and this is what you can see a iliac crest. This is a reflected portion of the iliac crest for a demonstration purpose. This is anterior superior iliac spine. If you come down, this is AIIS. Then you come down, then you can see this rectus femoris tendon, and in front of that you will see the iliofemoral iliopectineal eminence, and then this is the anterior margin of the anterior sacroiliac joint, and from here this is a separation between the true and false pelvis. So this is how you can expose and work from this approach. I will give you one example and the video of the same patient, how I have fixed this fracture. And if you see that there is a break in iliopectineal line as well as ilioischial line, but the obturator foramen appears intact. The major iliac bone appears to be along with the acetabulum. So this remains a transverse fracture where these are the CT cuts, and I start this performing surgery in supine position. So here you first mark the femoral vessels, take the incision, which is everybody is familiar, that is like somewhat like a anterior Smith-Peterson approach. Here, this is a umbilicus, this is a head end, this is a left leg, this is a ASIS area, this is over the iliac crest, and this is a vertical limb coming to the thigh. This vertical limb should be slightly curved outwards and should not go towards inner thigh. So once you complete your superficial hemostasis, you should be after two things. One is defining the white line of the iliac crest and then finding the lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh is very important structure in iliofemoral approach, where if you miss on that, the patient will have very bad meralgia parasitica. Now where I have palpated is a iliac inguinal ligament. I have taken a transverse slit, and then you can just below 1 centimeter medial to ASIS. So this portion is ASIS, 1 centimeter medial to it. I have taken an incision on the inguinal ligament, and then I have de-roofed this lateral cutaneous nerve of thigh. We feel that it is very thin structure, but no, in fact, it is very thick structure. And it is important that you should adequately mobilize the lateral cutaneous nerve of thigh, because when you do some manipulations near iliopectineal eminence, there is chance that you may damage the lateral cutaneous nerve of thigh. Then the next step is to perform the dissection like a third window of ilioinguinal approach, that is inside of the iliac bone. This is where ASIS is, osteotomy is planned. I have treated it. Then around 2 centimeter chunk of the bone is decided to osteotomize. So it is important to osteotomize and take it away. Once the anterior superior iliac spine osteotomy is performed, you are directly coming towards the AIIS. You can see the white structure which is seen there. The white structure which I am cutting right now is where the reflected head of the rectus femoris will come. It is important to tag the rectus femoris tendon so as it will be easy for our closure, and he will not have any loss of rectus femoris function. Some people don't ligate this, but I always ligate this rectus femoris tendon, so it's easy for reattachment. And once you have exposed the AIIS, you will directly land up on around 12 o'clock at the hip. Once AIIS is exposed, you will now search for iliopectineal eminence. So my periosteal elevator is now in search of iliopectineal eminence. Now I am clearing the fracture. You can see my forceps is touching to the quadrilateral plate very easily, so that you can reach up to this part. That confirms. Next important step is to take help of intraoperative lateral femoral pin traction, which is very important to lateralize the femoral head to help us to reduce the fracture. Then there are various ways. You have ting-tong forceps, you have unequal clamp, you have collinear clamp. So whatever fits well, you should use it. Now this portion of the unequal clamp is on outer aspect, that is a posterior aspect of AIIS, and the longer arm of this is gone into true pelvis. You can see this is the true pelvis, and it is reducing the quadrilateral surface. It is getting reduced, but still I am not getting the perfect reduction, so decided to come back. Here you can see a supra false pelvis acetabulum fracture, which I am temporarily fixing it with the help of KYS. These spikes are inside the true pelvis. Now I am using a collinear clamp. This is an excellent tool which I have, which helps in reduction of the quadrilateral plate very nicely. So this instrument is one of my favorite instruments for reduction. Now you can see the another reduction clamp in place and the neutralization with the help of latch screw that is called as suprastabular screw, which is from outside in. Now it comes the bent curved recon plate. The bent portion will support indirectly to quadrilateral plate and it will be fixed on ilium. Here you can see now how nicely the quadrilateral plate is buttressed and fixed with the help of interfragmentary screw. This screw is also called as magic screw. It may be from outside in or inside out, but the function of this suprastabular screw is reduction of dome and capturing of the quadrilateral plate. You may add the second interfragmentary screw to the dome to quadrilateral plate, achieving the reduction. This is the inside view. This completes the fixation. Now the third portion is fixation of anterior superior iliac spine osteotomy. But before that, I have forgot to take a drill hole through AIIS for rectus femoris. This is what I am tagging it right now. So rectus femoris is being now reattached to the AIIS. You can see now this is the rectus femoris tendon. Now it is attached, and once that is done, you can help using a screw fixation for the help of ASIS closure. This completes intraoperative video and then subcut and skin. This is the immediate post-operative picture of the same patient where you can see 1, 2, and 3 interfragmentary screws, a buttress plate, and osteotomy closure. These are Jude views, and this is obturator view. This is immediate after surgery. We have done the CT scan to confirm. This is immediate post-op CT scan, and this is union at the end of 1 year. You can see how nicely the acetabulum is congruent in both Jude views, in obturator as well as iliac oblique, and patient had good end result. So similar iliofemoral approach can be used in combined with posterior approach, which will we see right now here with transverse position, transverse fracture, where there is a displaced transverse fracture and anterior fracture. So there are many ways to bell the cat. You can do this with pure stopa. You can do this with stopa with iliofemoral. You can do this with iliofemoral with Cocker-Langenbeck. So you ultimately what you should aim for a good congruous hip. This is what you can see. There are 2 screws which here they are too important. This is how the posterior Cocker-Langenbeck is done in lateral position and semi-supine the iliofemoral. And you can see this a long screw. This is a posterior column screw which is passed from iliofemoral approach. And this is that screw in the other view coming from pelvic brim to the posterior ASIS posterior column near ischial spine. So this is that screw which is not possible to pass through only Cocker-Langenbeck approach. Then second, a KL type of anterior column screw which is holding the other component of transverse fracture. So in the end, you can nullify all the fracture line by using iliofemoral as well as Cocker-Langenbeck approach. So these are the other views, and you have a good Indian paper supporting the same. Another approach where you have a good displaced quadrilateral plate along with dome impaction. The head is medialized. Originally, we used to say the central fracture, but no more we are using this. This is a fracture where the anterior column is involved more. So here I have used iliofemoral window for dome impaction. People can do this also very nicely through AIP, that is modified stopa approach. Whatever you do it nicely, doesn't matter. Similarly, dome impaction is corrected. You can see the nicely corrected dome with the iliofemoral approach, a supported artificial bone graft and a plate. Then you take another approach, that is a Stopa approach to buttress the medial quadrilateral plate. And this is an immediate post-operative picture of the same patient having good congruous hip in both Jude views. And this is his union X-ray. So friends, modified iliofemoral approach is very easy. It doesn't have any vessels to dissect. It can be used in isolation, or we have seen now 3 examples where it can be used in isolation or with anterior Stopa approach or posterior Cocker-Langenbeck approach. Plating or column screws or buttressing Q plate is very easily possible. Exposure of AIIS is I will say, a lighthouse for variety of column screws. You can go for an anterior column screw, you can go for a posterior column screw, you can go for a LC2 screw, and in the end, it is a very easy closure. Just tag the rectus femoris, close the ASIS osteotomy, and your closure is over. Disadvantage, not beyond iliopectineal eminence of anterior column. If you have to do a lot of work beyond medial to iliopectineal eminence, then you have to convert that to ilioinguinal, classical ilioinguinal approach. Or if you can manage with Stopa approach, you add Stopa approach with that. Then it is not directly, it is indirectly supporting Q plate. And if you are not careful, you can damage lateral cutaneous nerve of thigh. Thank you.
Thank you, Atul. Now I'll request Dr. Pradeep to show his approach.
Do you have to take some questions here?
I think we'll take the questions at the end of all the 4 approaches.
Okay.
Dr. Pradeep is
Yeah.
finding some difficulty in the network.
No.
Go ahead.
Yeah. Okay. Is my screen visible now?
Yes.
Okay. So what I'm going to do is I'm going to run through a very quick PowerPoint presentation, and then I'm going to show the surgical video. So if you see ilioinguinal approach, it is one of the most traditional approach. If you see the history of approaches, emilia-luteal plays an very important role in evolution of the approach. So if you see the initial most anterior approach, that was the Smith-Peters-Helcom iliofemoral approach. Later on, when Letournel did his thesis, dissected cadavers, he was the one who described this approach. So we have seen in last talk the iliofemoral approach, which is a very good approach. The only drawback is that it limits your exposure and everything to the lateral side of the fractures. So although lateral side of fracture are effectively managed by the iliofemoral approach, however, in those era, more central fracture or medial fracture, taking a plate to the pubic symphysis and everything was almost not possible. But that's when emilia-luteal came in, and his work on cadavers and all patients, and he described this approach, which really is a landmark event in the history of pelviacetabular surgery. So if you see today, we have many anterior approaches. So we have the ilioinguinal approach, that is though it is not called, but it is almost the father of all approaches. Then we have the subinguinal approach, we have the iliofemoral Smith-Peterson approach, we have the modified Stopa approach, and then we have a new approach, that is the pararectus approach, which also is good in some of the indications of the acetabulum fractures. So currently, right now, the dictum is that we have the plethora of approach, and almost different fracture type. You can find an approach that is more suitable than other. And of course, surgeon expertise and his training also comes into picture when you want to decide which of the approach you're going to select a particular type of the patient. So today our job is to discuss the ilioinguinal approach. So now big note, if we see the current practice, my current practice, that I am going to do ilioinguinal in less than 10% of the patient. But that doesn't mean that we have to forget this approach, because as I said, This is the approach from which most of the other approaches are evolved. So it is very important that you need to know ilioinguinal approach in and out, because once when none of the approach will work, ilioinguinal approach is the one which is the one of the most versatile and complete exposure approach for the acetable. So if you see indications, these are the typical anterior injuries such as the anterior wall or column, and the associated fractures such as the anterior column plus posterior mid transverse both column. They also can be managed very effectively with the ilioinguinal approach. And sometimes transverse fracture, particular fracture where there is more anterior displacement, one may be tempted to go anteriorly rather than posteriorly. And this is the excess that we're going to get through the ilioinguinal approach. Whatever that is marked in green is the visual excess, and whatever that is marked in the red is the excess by palpation. However, this is just because it is marked in green, that doesn't mean that we're going to expose the entire of this area in each of the fracture. These are the area that is possible, and you need to just titrate your approach as for the reduction and fixation of the fracture mandates. So, but when it comes to the possibility, this is the kind of the exposure that you can get with the ilioinguinal approach. So, a little bit of applied anatomy. It's very important to know this before we discuss the ilioinguinal approach. So, if you see any area of the body where the girdle, from the girdle it goes to the limb. So we have a shoulder and it goes in the arm. So there are particular neurovascular structure or certain structure that go through that outlet. Similarly, if you see the lower limb, the inguinal ligament marks the border line there, and from there the pelvis and lower limb get separated. So we have different structure that are coming from the girdle, and they are passing down onto the lower limb, and these are the structure that we are going to encounter when we are going to expose the pelvis by the ilioinguinal approach. So one of the most bulkiest and important structure is the iliopsoas muscle, which is located in the triangular area, lateral aspect of the triangular area. If you see the inguinal ligament and the underlying pelvic bone, it forms a triangular osteoligamentous zone, out of which is divided into 2 or 3 areas. And in the lateralmost aspect of this area, we have the iliopsoas muscle. If you see, there is a medially that lacuna that is been remaining after we have filled the iliopsoas there, and that has been filled with the vessels. So medial to the vessels would be the femoral vein and the femoral artery, which are like the external iliac and internal iliac, proximal to the inguinal ligament. They change their name when they cross the ligament. If you see the femoral nerve here, that is lying on the psoas muscle, but that lies into the sheath of the psoas muscle. We did not dissect it during this approach. And this is a simplified version for the same. If you see this triangular osteoligamentous area, the lateral aspect, as I said, is filled with the psoas muscle, iliopsoas muscle, with the femoral nerve, and this is the sheath, it is iliacus fascia there. So this is the lacuna musculorum. Medial to that, we have the vessels, and these are called the lacuna vasculorum. Bang medially, we have some fibers of the pectineus muscle that comes into picture, and we have fascia that covers on that is the pectineal fascia. And this is the applied anatomy of the fascia reflections of the pelvis. So we have this inguinal ligament, which is nothing but the condensation of the fibers of the external oblique at the lower margin where they just roll up, and from there we have the superficial inguinal ring on the medial aspect, and we have the conjoint tendon which arch anteriorly and laterally like that, and that forms a deep inguinal ring. We'll come to that little bit later. This is from a different vantage point. If you want to see, we are looking from the inside now, and this is the lacuna musculorum. What we see is the femoral vessel. This is the sheath of the iliacus, also called as the iliacus fascia here, and this is the inguinal ligament. Medial to that are the vessels. This is the lacunar ligament, which is nothing but another condensation and reflection of the inguinal ligament, and this thick condensed tissue of the periosteum that lines the posterior superior aspect of the superior pubic ramus is called as the Cooper's ligament. So now if we see here, there is a condensation of multiple fascia at this point. So we have the iliacus fascia that is coming down here. We have the Cooper's ligament that is coming down here. What is not shown in the diagram is the pectineus muscle, and we have pectineal fascia that is covering the muscles, and that is also conversing at this area. We have sometimes another accessory muscle called as the psoas minor, again not shown in the diagram, that again come and inserts into this point. So this particular iliopubic eminence area is the point where lot many fascias come and try to condense. One particular note, if you see the iliacus fascia and if you see the anterior aspect of the iliac fascia, they tend to come from the inguinal ligament and they form a very thick band there. It's called as the iliopectineal band. Some people may call it the iliopectineal fascia or Poupart's ligament, different names. So one needs to understand this is nothing but the thickening of the anterior aspect of the iliacus fascia. Okay, so coming to the approach now, so we need to give a supine position, traction table if necessary. I don't do it in traction table, Western people do it. That may preclude some fixation, preclude the flexion of the limb that during the surgery. That's why I don't use it. If we have the liberty of giving flexion, you can use it. Limb drape free, that is what is my preference, and floppy lateral position if dual lateral approach is contemplated. Prerequisite is radiolucent table for your CM imaging, and we need to see that the CM is moving freely. There are no appendages of the table that are blocking the motion of the CM. And desired instruments are the Devers retractor, C-shaped abdominal retractors, multiple Homans retractor, Malibur retractor, like that. And we need rubber tape. And why do we need that? We'll come to that later. So this kind of draping that is being done. So generally the draping start around the hand breadth above the highest point of the iliac crest. From there we go to the umbilicus, then we come down to the four finger medial to the umbilicus, then we come down around 2 finger breadths below the pubic symphysis, and from the triangular area like this. So this is the area that is what is going to be our exposed area. So it is very important. What I can say, a miser kind of draping can cause a lot of problem in your exposure. So you need to know this clearance marking before you drape the patient, and it's going to save a lot of unnecessary struggle that can arise if you don't drape it. So that's why I included these sites that how to drape the patient. The incision typically starts around 1 or 2 finger breadth above the inguinal ligament, like that. Laterally we can either go above or below the inguinal iliac crest. Some people may take it on iliac crest. I don't like it to take it on iliac crest. I tend to take little bit above on the iliac crest when I'm doing a ilio-inguinal approach. So now after we have taken the incision, we're going to deal with the abdominal wall, and that will be the first structure that will be exposed after you have taken the skin and subcutaneous tissue. And what we are going to see first is the external oblique muscle. The direction of the fibers is like your hand is going in your pocket, like that. So that is the direction of the fibers, and at the medial aspect of that you will have the superficial inguinal ring. We know that through the superficial inguinal ring we have passage of the spermatic cord. So we can just split the superficial inguinal ring, take the incision around 2 to 3 centimeter higher than the inguinal ligament, and go it till the iliac crest. After that we cut the abdominal wall. Now what is shown in this diagram is that our incision is going through the muscles, but however we don't do that. We tend to take it from the iliac crest and take entire muscle insertion from the outer aspect of the iliac crest, and not we don't try to tend to go through the muscle. So this is the way what we actually go. We go very from the iliac crest. So when we see after we have taken the incision, we need to evert this, and in the gutter we'll find the inguinal ligament, and we need to split the inguinal ligament into upper half and lower half, like that. And that is the conjoint tendon which is anterior in lateral aspect, arches over like that, and goes posterior into the medial aspect. And we have spermatic cord like this, which goes from the deep inguinal ring to the superficial inguinal ring. So we split the inguinal ligament into in the superior half and inferior half, take our incision like that. Once we have done that, we will expose the lateral cutaneous, femoral cutaneous nerve there. So this is the way. Again, in the diagram it is shown that it is going through the muscle. So sometimes you can go through the muscle, or you can just split the inguinal ligament like that. So after you have taken and cut your dealt with the deep layer of the abdominal wall, what we are going to focus is on the iliopectineal fascia, which we have discussed when we have discussed the applied anatomy. So this is the iliopectineal fascia, which is nothing but the thickening of the anterior part of the iliacus fascia. So we cut the iliopectineal band or iliopectineal fascia along the line of the pubic ligament and also down onto the iliopubic eminence. That is how we cut it down to the pubic iliopubic eminence, and this is how we are going to cut it posteriorly along the line of the pectineal brim, like that. So we cut it like this and we cut it down like that. Once we have done that, medial to the vessels, we'll find a connection of the external iliac vessel to the obturator vessels, and these are the corona mortis. So these are the anastomotic vessels. So they, when vary in size, they can be very thin, or sometimes it can be anomalous origin of the obturator artery like that. So in that case, it will be very thick. So it's very important for you to identify and ligate those vessels, because in case they are big and they are ruptured, they can cause torrential bleeding, and hence the name. After that, we get the three windows. So lateral to the iliopsoas will be the lateral window, medial to the iliopsoas and the in between the vessels, that will be the middle window or working window, and medial to the window vessels would be your middle window. So to recapitulate, the lateral crucian of the thigh would be in the lateral window, and the corona mortis would be in the medial window. So this is how it generally looks on the table. So it doesn't look like this. So these are all atrophied muscles, and some the muscles are very bulky, and this is how we are going to see it during the surgery, and that is how we're going to see it during the surgical video. The closure is pretty simple. We close the abdominal wall in layers as we are cut. It is simple, but it is tedious. Then it takes a lot of time to close. We have to close it layer by layer to prevent future chances of hernia. Complications like vascular complication, lymphatic drainage obstruction, we can injure the lateral crucian of the thigh, we can have hernia or wound complications. So difficulties, sometimes we can have difficult reduction of the anterior most fractures, because anterior most exposure may be limited because of the tether of the inguinal ligament. It does not allow orthotomy. We need to take another approach such as Smith-Peterson or iliofemoral approach in addition to that to do the orthotomy. Articular impaction is little bit difficult to reduce through the ilioinguinal approach. We need to make a window as we have seen in the last talk, and trajectory of the interfragmentary screw is not possible sometimes. So that is the difficulties. So that's why there are different modifications. So there are many modifications described over a period of time. I'm going to focus only on two. This is the Karunakar's modification, where it combines the ilioinguinal approach with the modified Stopa approach, like that, and we can have a modified Stopa window in addition to the ilioinguinal approach. The specific use is the medial displacement of the quadrilateral plate. Another modification is a Cloynes modification, where you try to amalgamate iliofemoral approach into ilioinguinal approach by slightly modifying the incision like that, so that we can you can have this exposure as well. And that's how we has combined the iliofemoral approach into the ilioinguinal approach, and the particular indication for this is to do orthotomy or the anterior most low anterior column fractures like that. So that is regarding the ilioinguinal approach, and I'm just going to go very quickly through the video. Okay, before I start, is my screen and video visible now?
Yeah, visible. Screen is not visible yet.
Is it full screen? Black?
Yeah, now we can see it.
Okay, so it's a video. So in case you need, you just let me to stop, because this is continuous video, and this is the same draping and incision as we have discussed in the talk. And this is how our incision is slightly superior to the iliac crest. We go around a centimeter or two above the inguinal ligament. We mark the vessels after we have palpated them. I generally tend to infiltrate with the dilute adrenaline so as to decrease the superficial blood loss, superficial bleeders, because that can tend to be annoying sometimes. So that's why. After we have done the superficial dissection, This is the anatomy that we are going to see as we have discussed it earlier. So this is the external oblique muscles in the direction of your fibers like that. So can we see the direction of the fibers now? So this is the superficial inguinal ring. My little finger is going into the superficial inguinal ring, and these are the slanting direction of the fiber is the external oblique muscles. So I'm going to cut the external oblique muscle in line, starting at the apex of the superficial inguinal ring. You can avoid the superficial inguinal ring, go above it, you can go below it, but I tend to take it at the apex. Okay, so after we have cut the superficial, first we are going to go on the lateral window. So as I said earlier, we go on the lateral aspect of the iliac crest, not through the muscle. So first we'll expose the lateral iliac, the lateral part of the approach. So we take the entire abdominal wall muscle from the lateral to medial direction. Then we go from anterior to posterior direction. We don't want to go directly medially because that will tend to disturb the periosteum and cause bleeding. So first we are going to anterior to posterior, and then we tend to go down like that. And again, never be in a hurry to retract it, because we are still not exposed completely. Because if you overzealously retract it at this stage, again it will disturb the periosteum and will cause bleeding. So just elevate it and pack it. So now we are going to cut, as we have I have said earlier. So we are going to take at the apex of the superficial inguinal ring, and we take a scissor and we just cut it along the line parallel to the inguinal ligament, and this point should meet the lateral dissection. Now we have to be a little bit careful here, because at this point we can have your lateral cuticle of the thigh if it is superficial. It's actually deep to the conjoint tendon. So after your exposure, we tend to see like this. So here we can see this direction of the conjoint tendon. So these are the direction of the conjoint tendon. So these are the fibers which are arching over this. That's the iliohypoacoustic nerve, and this is the gutter where we can find the inguinal ligament. So here we have two choices: either we can split the inguinal ligament and take the part, half part of the inguinal ligament, or we can go through the muscles. So that's the ilioinguinal nerve, the iliohypoacoustic nerve that we have seen. So now we are going to cut the lateral aspect of the conjoint tendon as it is seen here. Try not to damage the ilioinguinal nerve that is there. So this is ilioinguinal nerve, protect that. And once we have cut the lateral aspect, we are going to see the lateral cutaneous nerve of the thigh. So that the lateral cutaneous nerve of the thigh. What we see here down here will be the iliacus. Now that's the deep inguinal ring. My finger is going into the deep inguinal ring. We know that deep inguinal ring is nothing but the aperture in the transversalis fascia. And this is the medial part of the conjoint tendon, the fibers which are arching over it and going and attaching onto the on the superior aspect of the pubic ramus, and that's the spermatic cord. So that's the medial part of the conjoint tendon, and I'm going to cut that like that. So it is tendinous, so you can just cut it with the cautery. It's not a problem. You can suture it later, because medial part of the conjoint tendon is tendinous. Okay, after we have cut the conjoint tendon, what do we see? So what we see here is the superior pubic ramus. So this is the superior pubic ramus and the periosteum. Here is the pectineus muscle and the fascia covering the pectineus muscle. Here it is my lollipop is on the Cooper's ligament. There's the periosteum, there's the Cooper's ligament. Yeah. Now, after we have taken off the abdominal wall, we expose the vessel. So these are the vessels. So this is the femoral artery, and this is the femoral vein. And what we are going to see down here will be the corona mortis. So before showing corona mortis, I'm going to show you how to cut the iliopectineal fascia. So first we need to expose the iliopectineal fascia. For that, you need to take a lollipop. So this is the iliacus. This is the iliacus fascia. We know that the anterior condensation in the iliopectineal fascia. So first we need to expose it. See, my finger is not going medially because the iliacus fascia attachment, it will not allow it to go medially. So false pelvis and true pelvis is not yet separated. So gently, gracefully take a mop, run it over the iliacus muscle, in between the muscles and the vessels, so as to separate the iliacus fascia from the vessels. Once we have done that, we can retract the vessels medially. We can put up tape around the vessels and we can retract that medially. So that is the tape, that's the glove on the vessel. And now what we have done is we have exposed the iliopectineal fascia. So this is the posterior part of it is called as the iliacus fascia, anterior part of it is called as the anteroiliopectineal fascia. What we see here is we are intrapelvic now, and that is the obturator nerve. Down there is the quadrilateral plate. And as I showed, that is the part where all fascia converge. That was the iliopubic eminence. So what we are going to do is now we are going to cut the posterior part of the iliopectineal fascia. So we just take a nick at that confluence, as I said earlier. Take a small nick there, and then we take a scissor and go posteriorly. That's a nick. And then we have taken a scissor and we go posteriorly along the iliopectineal brim to cut the iliopectineal fascia. Yeah, that's how. The posterior part of the fascia is pretty tenuous. We can even sometimes swipe your finger and it get dissected. What is the problem structure is the anterior part. So can you see my finger underneath? It is very tough structure. We cannot just burst through it. We need to cut it with a scissor, isolate it, protect the vessels, we cut it. Sometimes the incision go deep and we need to go deep on the posterior aspect of the iliopelvic eminence. Now comes the part after we are cutting the corona mortis. So in the medial to the vessels, we can see this is a corona mortis extra periosteal. If you are already taken off the periosteum and then you try to find it, you will never find a corona mortis. Corona mortis is extra periosteal. We need to find it above it. And that's how we ligate the corona mortis. We take a loop, ligate corona mortis, 2 sutures, and then we cut the corona mortis. Once we have cut the corona mortis, the vessels become free to be retracted on either side. Otherwise, the exposure will not be good if you are not cut the corona mortis, because it will be tethered. Now you can take off the periosteum and you can finally expose. So we need to add the flexion to the limb so as to relax the iliopsoas. We need to take off the iliopsoas completely, and from anterior aspect we can see the lateral canal of the thigh. So that is the lateral window. So we can see that is the entire lateral window. We can see that this is the medial window. So we can see that iliopelvic eminence is there, and we can deep down into the true pelvis we can go. And this is the middle window that is medial to the vessel, that is superior pubic ramus. And that's how we are going to do. The closure is pretty simple, as I said, but it's tedious that we need to suture each layer one by one as we are cut. And that's the end of the video. Thank you very much. I think that marks the end of my talk. We can take the question at the end, and I'll request Kali sir to proceed further with the program.
Thanks, Pradeep. Now I request Dr. Srinivas Kasha to come forward with his presentation.
Can you?
We can see your logo.
Okay. So good evening, Kale sir, Pradeep and Atul. I just want to share. Hope I am. Can you see my presentation?
Yeah, we can.
Yeah. So my topic is modified STOPA approach, AAP approach. AAP is anterior intrapelvic approach, or you have It's given to this particular approach. Your anterior approach, which was given by Salo, who is one of the pioneers for this particular approach, and extended fan steel approach by Collis and Bornhorn. So both these people have described this particular eventually. Now it is known as anterior intrapelvic approach. So the indications of this particular approach are any of the anterior column fractures and transverse fractures where you have anterior column involvement, anterior column with posterior hemitransverse, both column fracture, quadrilateral plate injury. So wherever there is anterior column injury, this particular approach is very much indicated. In fact, in combined injuries, you can even address the posterior components through this particular approach. So let me just describe about the approach, how we go about it. First of all, the position of the patient. So should be a completely radiolucent table. The host has asked me to, okay. So I just don't want to start my video. Yeah, because my internet is not good. So radiolucent table should be something like that, wherein your pelvis should be in a position where SIA moves in all the directions. So this particular thing should be made available, or we can even take the patient down by keeping both the feet on a Mayo trolley, do something and get a proper radiolucent table. The incision is either midline incision or a fan and steel. Both things are possible. The most important thing about this particular approach is it has, very small incision and very less blood loss when compared to other anterior approaches. And so this is the vasculature of the pelvis and acetabulum, which is obviously scary to see something like this. And our area of focus is that anterior column, and we are aware of these major vessels, unlike ilioinguinal approach where you are supposed to deal with them by dissecting adjacent to the vessels. No dissection of major vessels in this particular approach, and so it's purely a internervous plane kind of a approach. So like Pradeep has already mentioned, corona mortis. So in ilioinguinal approach or any other anterior approaches, it is difficult to see, although through this particular approach, it's by direct vision, you can see this particular vessel. So this is known as corona mortis, which is an anastomosis between external iliac and obturator vessels. You have got best visualization of this particular thing. So I can just show you a picture. In this particular thing, you can see an anastomosis between both. It can vary in its thickness. In this particular picture, it is almost as thick as your suction cannula, but usually most of the times it is very thin, which can be ligated through liga clips or use a ligature. So just I'll take you through one particular case example. Here in this case, you have got a T-shaped fracture with a central dislocation, and that's been fixed with this particular approach, anterior intrapelvic approach. So anterior column fixation is can be done and easily approached through this particular approach. That is, so deforming forces, like if you see a proximal tibia fracture where you have a posteromedial condyle, the deforming forces are posteriorly and inferiorly. Similar to that, you have got in central dislocation, your forces are towards medial side. So if you want to do something to reduce these fractures, you should be able to buttress it from inside. So those are the deforming forces which are to be buttressed from inside with various techniques of achieving the reduction during surgery, which is obviously possible through this particular approach. I'll show you. You can see this quadrilateral plate blasted out, and there is an articular depression which has been elevated. So, and grafted, that is after elevation of the depression, articular depression, which is also similar to the proximal tibia fractures where we do elevation of the proximal tibia fracture, right? Here, the same kind of a depression which has to be addressed. And most important thing is to buttress it from inside. So that particular thing can be done through this particular approach. So that is after achieving the reduction. So buttress of quadrilateral plate is best approach through this particular approach. So here is another example, T-shaped fracture, where both the approaches, KL approach and AAP approach was used. Can be easily combined with other approaches, iliofemoral and KL approach. Iliofemoral is like a buddy to this particular thing nowadays for me. So whenever I have any anterior column fracture, or whenever I have anterior column fracture with posterior minimally displaced, or the displacement be corrected with reduction is achieved through anterior intrapelvic itself, then I can even put a screw from iliofemoral. So there are various studies to support this, that ilioinguinal approach versus TOPA approach for open reduction and internal fixation treatment of displaced acetabular fracture. I can quote one example. Though both techniques can obtain satisfactory clinical functions in the treatment of displaced acetabular fractures, TOPA approach is superior to ilioinguinal approach in terms of operation time and intraoperative blood loss. And once you are used to it, obviously allowed to do that. So in conclusion, AAP is helpful when comminution of quadrilateral surface and posterior column exists. The complication rate associated with AAP is comparable to that reported for the ilioinguinal approach, and it has changed most of the pelviacetabular surgeons from ilioinguinal to AAP. And I'll just take you through the video. Sorry. This was an old video, so it's a cadaveric dissection. So I'll just take you through the video. So first thing is draping of the patient to above the level of umbilicus, which is important to just to have a midline idea during surgical exposure, or before taking an incision. So either you can take an midline incision or a transverse incision. The incision is around 1 centimeter finger width above the level of symphysis pubis in case of transverse incision, and the vertical incision is midline incision up to the from the level of symphysis almost to the below level of umbilicus. So here one important thing, once you take a transverse incision, something like this, in these cases one has to, after taking an incision up to subcutaneous fascia and identifying the anterior rectus fascia, which is considered to be one of the toughest structure, and which has to be restored after we complete the surgery. That means while suturing, this has to be done. to be restored. In case you take transverse incision onto the rectus also. Here one can use after reaching this place, even we can take a go in between the two recti muscles. And nowadays I prefer that particular approach, but in this case I took a transverse incision onto the anterior rectus fascia. So you can see linea alba, you can see the rectus muscle. So that is the rectus muscle, which should be elevated proximally and distally, and just bluntly dissect in between the two recti muscle. Put your finger and reach space of Regius. Space of Regius is space behind the symphysis. And once you reach that place, you can go in between the two recti muscles superiorly and just go on to the palpate onto the superior pubic ramus towards the fracture. So I'll just show you how to do that. Yeah. So that is in the space of Regius, and the first step is to put a anterior humans. You can see the bladder there. So most important thing is in this particular surgery, surgeon stands onto the opposite side of the injured acetabulum, not on the same side. So your visibility is anterior column and quadrilateral space. So that is the reason it's intrapelvic approach. And another important thing is to flex the hip all the time to relax iliopsoas. The first step is to use a Homan's elevator onto the superior pubic ramus, which retracts the rectus. This is the clinical picture, and you can see towards the foot end is towards left side and right side is your umbilicus head end. So superior pubic ramus, the first Homan's stands on the superior pubic ramus, and you just pass your finger to dissect the adventitious fascia and use a flexible retractor onto the bladder. So you just dissect the adventitious fascia and to find a corona mortis. So that is the vessel, which is anastomosis, which can be as thin as this one, and sometimes it can be as thick as almost half to 1 centimeter. Which has to be ligated before you go further in this particular thing. So the glistening structure which you are seeing is iliopectineal fascia, which has described by in the last talk, Dr. Pradeep has clearly mentioned how it is seen from ilioinguinal side. The next step is to take a sharp incision onto the iliopectineal fascia. So it is a very thick and tough fascia which has to be cut through a sharp knife. Make sure you secure this particular knife. Sometimes if it falls in, you may have the problems. So secure it with a thread onto the BP handle. Next, elevate this particular. So you can cut it almost up to the symphysis, this particular fascia, and elevate it from the periosteum to expose the anterior column suprastabular area. I'm just showing you the suprastabular place. So either you can use a COBS or a periosteal elevator. Here Bridgestone was used, and you can see the light source. So which is very important in these cases where you use AAP approach. If you have a light source retractor, that way makes your life very easy. So that is the suprastabular area which has been elevated, and your vessels are taken away along with this. So anteriorly. So anteriorly, the humans is going to stay there, and your blood vessels are off now. So what you are seeing thrombosed, or they cause a problem, you can choose to ligate them also. So you can easily use a iliac window to get rest of the access onto the iliac wing. Or nowadays what I am doing is to combine it with the iliofemoral approach as told by Dr. Atul Patil. So this is on the, yeah, you can see the iliac fossa. And this is from the inside once you pass a plate over the anterior column. So if you use, you can also see almost up to from the other side. This is from the iliac window. The plate is moving from that side to this side. That's it. Thank you.
Thank you, Srinivas. Now, if there are any questions, we will take the questions. There is a question from Dr. From Pune, I think.
Dr. Dheeraj Somnath.
No, there is a question from Pune. How to approach both displaced column injuries? Am I right? Modi? Hello?
Yeah, sir. It's a question from Dr. Dheeraj Somnath, Atade, Pune, that at all facilities, how to approach both displaced column injuries.
See, as a beginner, if you are not accustomed to the AP approach, you will have to use simultaneous approaches. You can use the ilo-inguinal approach for the anterior column and the KL approach for the posterior column. You can either do it simultaneously in the same sitting or you can stage it. One thing you have to remember is when you are fixing one column, you should not bite on the other column, because if your screw is holding the other column, and then you turn the patient for the KL approach, and if there is a mal reduction, you cannot do anything. You just cannot do anything. So you can do it in two different fashions, either the AIP or sequential approaches. Any other question?
Yes, sir. There is one question from Dr. Shanti Sarup Vrikriti. That is, what's the difference between STOPA and modified STOPA approaches? What is the difference between STOPA and modified STOPA approach?
I think
approach actually was.
Srinivas Kasha will answer it.
Yeah. STOPA was actually described for recurrent resistant hernias. So modified STOPA is used mainly for for orthopedic surgeons. That was STOPA surgery. STOPA initial exposure mainly was for recurrent hernia repairs using a mesh onto the pubic radius. So So modified is actually speaking, modified stopa is what? Hope I am right, Pradeep.
Yeah, I think it's absolutely spot on that. The Stopa approach was not described by orthopedic surgeon, it was described by general surgeon. And slowly we took it in our armamentarium, and people started calling it modified Stopa. But then right now, the extent of Stopa approach that we are using is almost it's exponential. The Stopa approach that was described by Stopa is a very small approach, but now we are exposing the almost the entire two pelvis from inside, and that's why the contemporary people in this want to call it as the anti-intrapelvic approach, not calling it as a Stopa approach, because Stopa described only a small part of it, and the major part that is being performed by orthopedic surgeons is entirely different, and that's why it's altogether different name. It's an anterior intrapelvic approach. That is a suitable name for this approach.
For Stopa, do you cut rectus sheath vertically or transversely?
Yeah, so right now I think everybody is trying to cut it vertically. There are one way where we try to cut it the anterior rectus sheath horizontally and split the rectus muscle vertically. Under no circumstances we are cutting the rectus muscle or rectus tendon. Previously we used to cut the rectus sheath horizontally and split the muscle, but nowadays we are like cutting the rectus sheath right in the center.
So with that, you can have a great access to pelvic structure.
Yeah.
So that's a big difference, because I have done both things and found that cutting it vertically really extends your approach very well.
Atul, are you talking of taking the AIP vertically or AIP?
That doesn't matter, sir. But cutting the rectus sheath vertically matters.
Yeah.
Yeah, agree with Atul. Yeah.
Actually, it is the extension under the fascia that you go higher up and lower down, which is more important than your extension, your length of the AIP approach. We really have to go much below the symphysis because the rectus inserts anteriorly much below.
Right.
Then you can flip the rectus.
That is only when you take a vertical split.
No. I am talking of the insertion of the rectus on the symphysis. We all think that it is on the superior surface. In fact, the rectus sheath goes much more anteriorly and inferiorly.
Yeah. So one of the point that initially we used to take the incision horizontally. Now one of the problem is that suppose this incision it needs to be not too high, not too low, just perfect, around 1 or 2 finger bits above the pubic symphysis. Then only you can open it. If the incision, this horizontal incision, becomes a little bit higher, then it starts giving problems. Sometimes in the distal part of the limb, we need to make a horizontal split like a T. So that's that this particular problem does not arise when we are splitting it in the vertically down like that. So that is another advantage of cutting it in the center.
Modi, any more questions?
Yes, sir. One question from Dr. Navneet Baduni. Is there any difference in midline and fenestil incision in Stopa approach in terms of exposure?
That is what we have.
Yeah.
No. The question Atul is asking is the primary skin incision, whether you want to go vertical or horizontal.
Yeah.
Can I answer that? Yeah.
Yes.
Yeah. So now many things are confused because of the terminology, and I would like to make it pretty clear. Now, number one is more common is a fenestil incision.
Fenestil incision.
Yeah. So there are 3 things that one needs to keep in mind. Number 1 is the skin incision. Number 2 is the incision on the rectus sheath. And number 3 is how we are going to handle the rectus muscle. Okay. So now going one by one. Number 1 is the fenestil incision that we say. Traditionally, what used to be done that horizontal skin incision, horizontal cut on the rectus sheath, and even people used to cut through and through to the rectus tendon horizontally. So that was the traditional phalangeal incision and phalangeal approach that was considered. Now this approach was primarily used only for the symphyseal plating. It's extremely dangerous if we want to extend this approach laterally, because once the recti tendon are cut, we have nothing but the vessel that is coming in the just lateral to the rectus muscle. So this exposure cannot be widened laterally in the same go. So that is number one. That is sometimes called as the phalangeal
It can be
incision.
widened, but you are putting, it can be widened by retractors, but then your retractors are going to press on the vessels.
Yeah. So this is particularly phalangeal incision and phalangeal exposure. Again, this was used for the cesareans and all, also that has been changed. Number two is that we can take a phalangeal incision but do a AIP exposure, that is split the recti in between and go and do the AIP approach. That is number two. And number three is that you take the skin incision also vertically and split everything vertically, just like a laparotomy. So that is number three. So these three things need to be kept in mind when you are discussing the semantics or the nomenclatures of the incision. So phalangeal incision, when you say phalangeal incision, it is the incision on the skin. So for right now, what we are doing in AIP approach, that we are taking phalangeal incision, but the approach is AIP. We are not doing phalangeal exposure that was traditionally used when we used to cut the rectus tendon. We are not cutting rectus tendon anymore. We are splitting the rectus tendon in midline, as far as possible rectus sheath also in midline.
What
I
is the
hope
harm?
that answered the question.
What is the harm in taking a skin incision vertical?
There is no harm that the skin incision has to be very big and it may not be cosmetic.
But
Harm
This is
cosmetic. Does it not give you more lateral retraction of the recti?
no.
I don't think so. It adds to any this thing. Unless the patient is very obese and that horizontal incision is going to be very big, then in that case we can take vertical incision. Otherwise, in fact, I think this retraction of skin is more difficult than retractors of the recti. I think Dr. Atul Patil will agree with me with this.
Yes, yes. And horizontal incision is much beneficial, because if sometimes you feel, no, now I want to control this for a better control of anterior column wall as well as some column area, which I will not easily access through STOPA, then third window and the AIP approach is better that you do it in financial. Most important here is two things. Again, once you take a horizontal incision on the skin, it is important that you free the subcute till umbilicus. Second, if you take vertical incision on rectus sheath, as high as possible, take it as high as possible. And third, once you separate the linea alba, put your finger below linea alba and the bladder very gently but very extensively towards the superior surface. Then automatically your recti will cover your external iliac vessels and you will get retraction. Any more questions, Nitin?
No, sir.
So shall
There
we
is no
call
any
it
more
a
questions,
day?
sir.
Then we can stop going live now.
Modi, I think we will call it a day if there are no more
Yeah,
questions.
yeah. There is,
We can make it offline.
yeah.
I really thank Nishiro Pharma for inviting us for this talk. It has been really great to interact again with we interact every week, but always new things every time when we interact together. Always
Thank you.
something to learn.
The problem with the Zoom is, I hope we are now offline, na?
No.
Modi?
No, it's still live.
We are still there. So good evening. It's a very wonderful good evening. And I thank you to our viewers and I thank you to our speakers, Dr. Dinesh Kale sir, Dr. Pradeep Nemate sir, Dr. Atul Patil sir, and Dr. Srinivas Kasha sir. Good evening. Thank you and good night.
Modi, are we offline now?
No.
Relay stopped?
No.
Chintan ji, hello. हेलो चिंतन जी, हेलो चिंतन जी,
Hello. Are others on the line?
Yes.
Public broadcast बंद झालाय की नाही?
नाही.
What this say on custom line streaming service?
हाँ सर.